Welcome to the Birth Journeys podcast. I'm your host, Kelly Hoff, BSN RN. I am a wife, a mother of two, and a nurse specializing in the care of women and newborns. In this podcast, we will share powerful journeys of birth givers with the goals of lifting the veil on the birth experience, healing through sharing, and beginning an open conversation to strengthen trust and promote transparency between birthing people and healthcare providers. Hello. Today I have with me Dr. Stephanie Waggel. Dr. Waggel is the mother of two and a psychiatrist specializing in perinatal mental health. Today we are going to talk about medications in pregnancy and postpartum. Dr. Waggel, thank you so much for joining me.
Thank you for having me.
So I know this is something that you are so passionate about because a lot of people are scared to give women medications in pregnancy. So
Oh yeah. I have my friends call up. They'll be like, "Hey Stephanie, one of my patients is pregnant now and I'm not sure what to do." And I'm like, "Well, didn't you go to medical school?" So one of the reasons that this happens is because perinatal mental health is not routinely covered in medical school and residency. And there's a lot of conflicting information. And when patients get conflicting information, it causes mistrust. One of the reasons, and I'm sure you can guess, is because it's not exactly ethical to do research studies on medication with pregnant women. Like, you can't just take a bunch of pregnant women and say, "Okay, you pregnant women are going to take this medication and we're going to do placebo." Like, you just can't do that. That's not super ethical. So there are no double-blind placebo-controlled trials. What they can do is they could have retrospective studies. So if you find out later that a woman did take a certain medication while she was pregnant and it was her choice, you could look and see what happened. But the problem with that is confounding variables. And for those of you that don't know about confounding variables, that's when there's other things also going on that are associated and that could actually be the cause of what happened. So you have to tease those things out. And that makes interpreting the data pretty difficult. So we don't want to just blame healthcare professionals for not knowing. It's also because it's like a sticky situation. It's really actually hard to know for sure. But what I do with my patients is that I find research and I say, okay, this is this study and what it said. But if you also look, like, all the pregnant moms in this study were also smoking a pack a day. So, how much weight do you want to give to this study and this sort of thing? So you can't just take generalizations, but you can sort of go on a one-by-one basis and review the research with patients. But of course, that takes a lot of time. So if you're at your OB, they're not going to have time to discuss your constipation and heartburn and then also get out like 5-page journal articles and reviews. So it creates some problems, but it can be done. So that's one thing. It's that there is research. So to make things better in the future, pregnant persons can sign up if they're going to take a medication anyway, voluntarily. They can sign up to contribute to the future of the research. So that's the National Pregnancy Registry for Psychiatric Medications. And I can give you the number to call. The problem with that is if a woman is pregnant and having mental health issues, like, she's probably super busy and doesn't have the time and energy to enroll in a study. So, that's another barrier. But by some off chance she has one day where she can call that number, it would be very important for future pregnant persons to have that data. Because like I said, you can't just hold a research study and put half of the pregnant people in one group and half in the other, but you can voluntarily take a medication and then provide the information for people in the future. And speaking of barriers and things that are making this field a little bit complicated, is the healthcare providers. I just made a video on my Instagram about this. It was funny because I said, healthcare providers don't want to cause you harm. And then I was like, well, most of them don't, because I'm sure there's a few corrupt ones out there. But I mean, most of us don't want to just cause anybody harm. So whenever they say don't do that or don't take this medication, it is because of that direct relationship to a negative outcome. So if there is treatment and it leads to some kind of negative consequence, then healthcare providers feel guilty. They feel bad about it. But if there's failure to treat or lack of treatment, or they say, okay, don't do that, and there's a negative outcome, that close tie isn't really there. The connection isn't really there. So the guilt isn't really there. So treatment can lead to risk and benefits, and non-treatment can lead to risk and benefits. But healthcare professionals are more reluctant to do the treatment that leads to a risk because it's like there's a direct connection. Now, that kind of brings me to something that maybe people don't really know is that there is a negative to non-treatment. So, and without getting super duper technical about like gene methylation and those sorts of things, I'm going to talk about what happens if mom is not treated and the fetal communication. So whenever the baby is in the womb, there can actually be genes turned on and off. So let's say that mom was having a whole ton of stress and she was doing okay on a medication, but then she stopped the medication and now she's super duper stressed. So we're talking about the harms of lack of treatment. So mom has really high prolonged stress that can actually lead to preterm birth. And then, like I was saying, changes in the baby's genes, increased methylation at the promoter region, but I don't want anybody to fall asleep. So just suffice it to say that mom being really stressed can actually have effects. There's this thing called the hypothalamic pituitary adrenal axis, HPA. So it involves glucocorticoids. I think most people know what cortisol is, like the stress hormone. So if mom's super stressed, that can make the baby stress response hypersensitive, and that can lead to the baby later on having hypersensitivity to stressful reactions. So to kind of back up and summarize what I just said, when mom does not get treatment, there can still be negative outcomes. And aside from the very scientific and genetic negative outcomes of mom not continuing her treatment, mom stopping her medication because she's pregnant, relationship problems, disability, unemployment, poor adherence to other medical treatment. So if she stops her psychiatric medication, then maybe she becomes depressed and then can't get the motivation to get out and go to her regular OBGYN appointments or endocrinologist or things like that. So it can affect her ability to adhere to other medical treatments. Women who stop their mental health treatment when they're pregnant has a higher chance of child abuse and neglect, because if you have uncontrolled mental health issues, you probably aren't going to be in the best state to be able to take care of your child. Also, they've shown that uncontrolled mental health episodes during pregnancy or increased stress during pregnancy can lead to the baby having developmental delays and behavioral problems. And kind of tied into the not being able to adhere to going to your other different types of doctors is its exacerbation of medical conditions. So if you have diabetes or something and you're not following up, you may not be able to feel pain in your foot, and then you get an ulcer and then it gets infected. So it can spiral into all these other things too. And then also it affects your relationships. So there's higher rates of separation, divorce. And then if you cannot get your medication either because your healthcare provider didn't want to have that direct cause and effect, as we were just talking about, they didn't want to prescribe you something and then something bad happened, you might turn to medications that you don't need a doctor for, like drugs and alcohol, which obviously lead to problems of their own. And then there's also loss of interpersonal resources, financial resources. So not getting treatment or discontinuing medication, people don't really realize it a lot of the time, definitely has risks there.
Right. I really wanted you to like nerd out on the methylation, but that's probably going to be...
I want to keep people engaged.
I'll be engaged, but we might lose the audience. So
we'll talk later.
Yeah. So then you had mentioned in our previous conversation that it isn't just the mental health medications. It's also people not wanting to prescribe an asthma inhaler or just stuff that people would need.
Yeah. The individual who has asthma and then she went to get her steroid filled and the pharmacist saw that she was visibly pregnant, which You should never just look at somebody and assume they're pregnant. Like, that's a whole different talk that we could have. But this pharmacist looked at her and was like, well, you're pregnant. I'm not filling this. And then she's like, oh, so I'm just not going to breathe. That's a really, really great alternative. But again, it's that direct connection. It's like, okay, well, you're not going to breathe, but I didn't give you the thing that's going to cause it. It's like the lack of prescribing or dispensing the medication. They feel like they're absolved of any issues, but that's not at all how it works.
But refusal of treatment isn't exactly do no harm, you know? It's
no, it's certainly not. And so I had mentioned that sometimes when individuals stop their psychiatric medication, either because their provider didn't want to continue it or the pharmacist freaked out and saw that they were pregnant and wouldn't prescribe it, and then women turn to drugs and alcohol. I actually have this quiz because it's kind of a 50-50. It's hard to guess. So if a woman is on opioids and she is going to a methadone clinic and you find out that she's pregnant, and this is actually a quiz for pretty much doctors, and I don't even know if they would know the answer. I guess I'll find out next week when I do grand rounds and I do the pop quiz. But okay, option A is either to taper the mom off of her methadone and discontinue the methadone while she's pregnant, or B, continue her methadone maintenance during pregnancy. So, I mean, I feel like I bet you could guess.
Yeah, because I've had babies that their moms have been on methadone during pregnancy.
Right. So some doctors and healthcare providers think, well, mom shouldn't be on something like that. Let's stop it. But the research actually shows that you're supposed to continue the methadone maintenance during pregnancy.
And I think we give babies the methadone and taper them off of it as well.
Right. Well, I'm not really sure what we give the babies. I did work in the NICU. I'm not really sure what the babies were getting, but I do remember that the babies that were withdrawing from moms that had opioid dependence were always yawning. So I'm not prescribing medication to babies, but I prescribe the medications to moms. So I can't answer that one what the babies get, but I do know that you continue the mom's methadone.
Yeah. And you give something to the babies. And I just don't remember because I know we'd have to go through this whole scale, which it sounds like I think we just got some literature on they've changed the scale. But anyway, it's like you have to go through and look at the baby's tone and the quality of the cry and like the respiration.
Right.
I want to say somnolence, but that's a big word, that their alertness.
There we go. See, you gotta skip those big words.
Switch into normal people words. Yeah. So then you create more problems if you don't continue with the methadone, because then what do you continue with? Because they're going to take something. They're going to feel like crap.
Yes, exactly. So I guess that's like an important thing for providers to know. Patients might need to know that too.
Yeah.
Another thing that is important, I am so surprised and shocked every time I hear another doctor use that letter system for, oh, that's a category B. I'm like, what? How old are you? When were you born? It was abolished in 2015. It was abolished on June 30th, 2015. But my colleagues will talk about, oh, that's category C. And I'm like, it hasn't been category C since 2015. That's almost 10 years ago. What are you doing? So I don't know what's with the lack of updates, but the FDA, I have a link to the FDA's consumer updates for pregnancy and breastfeeding. So they changed a lot of how they categorize things. Now, instead of using the letter system A, B, C, D, and X, they actually use what is called risk summaries and clinical considerations. And it's because a lot of the trials and the information were really with animals and things like that. And now what they do is they kind of do what I do during appointments and point out different studies and things and how it could relate to you more personally. Some other changes that they made is they have drug labeling include labor and delivery in the pregnancy section. So if you ever, have enough time and you want to read that really long insert that comes in your medications, it is 8.1. That's the pregnancy section. And nursing mothers is now called lactation, and that's 8.2 of the medication guide printout. And they have a new section, 8.3. This section is called females and males of reproductive potential. Because I guess if people aren't really familiar, now we say like pregnant persons, it could be a biological female who transitioned to a male, but is then still able to get pregnant. And so that's where it would be the males of reproductive potential. So that's 8.3. So I think it's important for healthcare providers to like realize that things get updated, occasionally.
For real.
Keep up with it a little bit. And another thing that I think is important when it comes to staying updated with the terminology is I think most people are familiar with postpartum depression. But what I have been explaining now is PMADs, and that encompasses more individuals in two ways. Instead of it being postpartum, which is obviously after you have a baby, it's perinatal, which is from conception to 1 year after birth. So that encompasses like a larger time frame. The other part of that is that it doesn't just include depression, it's mood and anxiety disorders. So it can be like OCD or PTSD, anxiety, other things like that. So before, where if it was postpartum depression and you were like 3 months pregnant with anxiety, I guess that doesn't include you. So I guess you'd be left out. But now PMAD, it's more encompassing. So I just like to point out that I try to say PMADs. And the other thing, so we just talked about the difference between postpartum depression, perinatal mood and anxiety disorders, but now I need to differentiate between the baby blues. And so this is one of my fun trivia questions to ask you. What percent of moms do you think get the baby blues? And most people will get it. They're like, 70 to 80. And yeah, it is. It's really super high. And that is mostly due to hormone changes. And it's from a couple days to 2 weeks after delivery. But if you're having those symptoms for longer than 2 weeks, then you might want to get a little evaluation for PMADs. But the baby blues is super common, but just remember the 2-week time frame. And another, I was going to say fun fact, but it's actually like
Not so fun fact?
It's a not so fun fact that perinatal depression is the most underdiagnosed obstetric complication in America. So not a fun fact.
Yeah.
Maybe it's interesting fact, but it's, I don't know, maybe
important to know fact.
Yeah, maybe we could change this fact at some point. So I want to stop and see if you have any questions so far and make sure that I don't know how much time I could go. We have so much time.
We have so much time. You are totally fine.
All right. There's so much to talk.
There is. So say someone is taking medication before they get pregnant and then they get pregnant and hormones change. Do you often find that you have to make tweaks to the medication dosage during pregnancy and postpartum?
Are you pregnant and planning a hospital birth? You don't need a birth plan. You need a birth vision. In my opinion, birth plans set you up for failure. Yep, I said it. Hear me out before you turn off this podcast. You may think that by downloading a generic birth plan, it means you're in control. The truth is, it's not that simple. No one can control exactly how their birth will go. There are way too many variables. What every pregnant person wants is to walk into the hospital pregnant and to walk out with a healthy newborn in their arms. The journey in between is the murky part. It's hard to know what issues might come up that need to be addressed. If you focus your energy on a birth vision rather than giving your power to a birth plan, you can empower yourself to make the best choices for you and your baby. That's why you need to get into my Empowered Hospital Birth program. As a labor nurse and mindset coach, I can help guide you through the process of maintaining the calm autonomy that will help you achieve the birth vision you desire. In my Empowered Hospital Birth program, I will help you identify the source of anxiety you have surrounding hospital birth, fill in knowledge gaps to make sure that you are fully informed and confident, learn key phrases so you can better communicate with your medical team, emotionally process your fears so that they don't hold power over you. Go to kellyhoff.com/empowered to book a free 30-minute private birth vision call, where we will identify your top fears and must-haves and gain clarity on exactly how you want to feel in the birth space. That's KELLYHOF.com/empowered. I'm honored to be a part of your birth journey.
Oh, this is a lovely question that takes on, there's a lot of facts that
I
that
figured
get
you'd have a
into this.
lot to say about this one.
Oh, yes. Okay. So I'm going to start with the general idea. So when I talk to OBs, some of them just, don't like psych meds in general. And again, this is so generalized. Of course, things are really person-based, but in general, if the psych medication is currently helping, do not decrease or discontinue it, except for if it's Depakote. I won't get into that for the sake of this talk, but some prescribers think that it's a good idea to decrease so that the baby's not exposed to as much medication. But the problem with that is that the baby's still exposed to medication, and now the baby might also be exposed to untreated mental health issues, getting back to what we talked about before with the glucocorticoids and the overwhelming their system and, all the things that I named before. So if you decrease the dose, and if they're on a dose and it's working fine and you decrease it, then the baby may be exposed to all the stressors and issues that we named before, in addition to the fact that they're still being exposed to the medication anyway. So decreasing it is not a great idea. Of course, there's a lot of factors, but this is just the generalization. Now, there are some medications that you increase because of the volume, the volume that you could think that you have expanded, right? So there are some medications that I can order blood levels of just to see. And of course, even with like red blood cells, you have the dilution during pregnancy where it looks like you don't have as many, but it's just that you're like Violet from Willy Wonka and all swollen up. So some medications, because of the increase in fluid, you have to actually increase. But what I really want to point out is don't just decrease it just because you're like, oh, like less will be better for the baby.
Yeah, definitely. With those cortisol levels going up, that's not.
No.
You're exposing the baby to something, whether it's what your body makes naturally or whether it's the medication that we're giving you so that your body doesn't make that thing naturally. You're going to be exposing your baby to something.
Right.
I don't know if this is a question, but just something that I've learned. I understood postpartum depression when I had my kids. I was looking out for that, and I had all those questions from the Edinburgh scale and all that stuff. And I never really experienced anything on that scale. I was really motivated to get out of bed and take care of my baby. I wasn't overly tired, other than the fact that my kids don't sleep, and they still don't. And that's a whole other thing. But I didn't realize that when I had irritability and when I had thoughts about things that probably weren't in my control, that those were symptoms of some of the PMADs. So can you elaborate on some of the other things that people would want to look out for?
Yeah, absolutely.
Not just postpartum depression.
So I definitely want to make a check mark or discuss in a moment about unwanted thoughts, because that's one of the most important things that I tell people. But briefly, as long as we remember to go back to that, I'm glad that you said the PMADs, because well, I guess if you're from Scotland, it would be Edinburgh.
Yeah, I have a friend that's Scottish that's a nurse, and she says Edinburgh, so that's how I say it. But
yeah, so however you want to say it, depending on where you are, that scale is actually pretty much the gold standard thing to screen. And I just want to put in parentheses real quick. If you're going to screen, make sure there's follow-up.
Right.
End parentheses. I won't go on too much. That's definitely the gold standard, the thing that you should take. But it's for depression. So like we were talking about earlier, postpartum depression, but there's so many other things. And so you could be having symptoms of things that are not depression. And so if we go to the unwanted thoughts, and this is the part where I wanted to do my disclaimers at the beginning, but one of the disclaimers is trigger warning. So there are just some things that I'm careful not to talk about. And so if I talk about unwanted thoughts, I'm careful not to talk about like any specific ones, because anybody that listens, I don't want them to start, having unwanted thoughts. Right. But when it comes to unwanted thoughts, one thing that I tell people that like huge weight off their shoulders, this is where people write, Dr. Waggel saved my life. Like this is like one of the biggest, most important things that I can tell people is that I have a hard time wording this because I have to use the word crazy, which I don't like to use the word crazy, you know, but people want to hear that they aren't crazy. And so I think when people say that, they're thinking about psychosis. And this is why I'm careful, because I don't want to say that people have psychosis or crazy either, right?
Right.
But this is just like how the word is used by, non-healthcare professionals. And so even if you have psychosis, like that's treatable. Like you have too much dopamine, there's medications for that. We can treat that. But I think people are worried that they are having psychosis and that if they tell me about the unwanted thoughts, I'm going to like involuntarily hospitalize them. Of course, that has happened. And like I said, it is treatable. But 99% of the time, those unwanted thoughts are what's called ego dystonic. And that means that the unwanted thoughts are bothering the individual, which is a sign not of psychosis, but of OCD. And so OCD is one of my favorite things to treat because it is just so receptive to high dose SSRIs. I can't even think off the top of my head somebody with the OCD symptoms. Okay, wait, I have 2 patients that I had to try other things, but like most of the time with OCD, unwanted thoughts, high dose SSRIs, they either don't have the thoughts anymore or the thoughts that they have, they can deal with and are not debilitating. So when the moms come to me and again, I'm going to try not to say any specific ones because I don't want to trigger anything, but they're usually very terrible thoughts that make people feel like they're quote unquote crazy. And so I'm like, well, no, this is actually very common. The fact that you're worried about it means that it is not psychosis. It's pointing to an anxiety picture, OCD, very easily treatable and very common. And people are just like, oh, I thought I was the only person on earth.
Yeah.
I thought I was going to have to go to the hospital. And when I tell people this, it's like they leave a different human being. And they're like, oh, I thought that I was going to, be put in a straitjacket and all these things, which I've never worked at any place that did that anyway.
Right.
I don't know. I think maybe people watch too much TV.
I think they do.
Like people come in and think that all these really horrible things from movies are going to happen to them. And so, no, I'm like, look, these thoughts, this is anxiety. This is very common, very easily treatable. Ego dystonic, meaning the question that I have is if you have a big red button in front of you and you press the button, it makes it go away. Would you? And they're like, yes. And so that's OCD. And then there's 2 other things. There's OCPD, which is they're not bothered by it, but it's just more like they like to have things lined up a certain way, or they like to be very clean, or they're very rigid. And that's kind of like what you see on TV. And that's not harming anybody. It's not getting in the way of their ability to do things, and they like it that way. That's one way that the thoughts could be egosyntonic and not be problematic, as if it's OCPD. And then the third option, they're egosyntonic, meaning they're okay with the thoughts, but the thoughts are like your baby is a demon or something that is like really harmful. And then that can be psychosis. And even still, we're not barbarians anymore. There's treatments for that. And it's a little bit more difficult to treat than say OCD or something, but there's still treatment. So I don't want anybody to sit at home and think that all these unwanted thoughts are rare and going to lead to some kind of terrible outcome. They're like so common. I have somebody at least once a day that tells me about them. And I just love telling people that like, hey, it's common and it's treatable. And they're like, oh, really? That's great news.
Yeah,
so I definitely wanted to point that one out.
Oh, for sure. I love talking to new moms and being like, what are your thoughts? Because everybody's got something. But it took me years to figure it out. Like, and I didn't even know I'd had the thoughts and I recognized them as dystonic. I recognized that was weird, Right. It wasn't until I feel like it definitely was OCD. And I had a couple of thoughts. There's a person that was carrying a gun in our neighborhood that had some racist flags also. It was really just bad. And like, I was like thinking, I was researching how to put Kevlar around my daughter's crib at 3:00 in the morning. I was doing that a lot. That felt a little OCD and like a big waste of my time.
That's the point. The waste of your time. So there are some things to a certain point where it could be productive. Like if this person like was very just like firing into the air, like then maybe that would be a good use of your time.
Yeah.
It's really how much it impacts your ability to get things done and your activities of daily living. I guess if it was just one night for 10 minutes, then, that's
it was for
not
a while.
really, if it was keeping you awake
It was.
and then subsequently you were tired the next day, then that does affect your life. And then it could, get to the point of clinically significant. But, if it's just once for 10 minutes, then it's like, oh, that might have been a good use of your time. So it really depends on how much time it took out of your day. Although, I mean, this neighbor,
he's gone.
Would give me anxiety.
Yeah,
too,
he's gone.
so.
We did, the HOA got involved, and ultimately
The HOA, your flags, they don't match everybody else.
Right, your flags in your open carry situation. Kind of disturbing
not
for
the
most
vibes.
people. It's really not. That's not what we're trying to go. Plus, also, you can only have seasonal flags in our neighborhood. And so I was like, why can't you guys do anything about the fact that they are racist flags? Like, what?
Yeah, like
this feels wrong.
Did they change the racist flags with every season?
Are they now?
It's
is
like
it racism season? What's going on?
Right. It's like the goose that has like the Christmas outfit and then like the Valentine's outfit. Only they do the same thing with racist flags.
Right, exactly. It's October. It's Nazi month.
Makes it, I guess, as long as they change it, the HOAs are okay. Yeah, but I definitely would have been nervous about that. I might have been Googling too. But the big factor is how much it affects your ability to get other things done and impacts the things that you want to do.
I don't know if I had any other questions. Did you have any other things that you wanted to talk about?
Well, I did want to briefly mention, if I can, the free support group.
Yes,
that
that's
we're
so
offering.
important. Yes.
So I had mentioned the disclaimers, and those are the things that I say at the beginning, like with the triggers. I also say what I'm saying isn't medical advice, but it would be if you scheduled an appointment.
Yes.
But it has to be
if
like
it's appropriate for that
for that
patient. Yes.
Right. It can't just be like, here's some blanket advice. It's perfect for everybody. Like that would be great, but that's not how that works. But the group, so it's interesting. A lot of people don't know the difference between a support group and a therapy group. And so a therapy group is led by a licensed professional, which I am. So in that respect, it's a therapy group. But because it's open and people can come and leave and people aren't required to come every week and people are allowed to talk and be friends with each other outside the group, that makes it a support group. If it was a therapy group, it would be closed. Everybody would have to come every single time. People wouldn't be able to talk to each other outside. And so it's pretty much a support group, but led by a licensed professional. Since everybody's either pregnant or a mom, I don't want to be like, you have to attend every single week. Like, this is like too much commitment.
Right. That then becomes a stressor. Yeah.
Yes, exactly. That defeats the whole purpose. So it's very free. People can come late and leave early and come one week and not the other week. And so in that respect, it's a support group. It's on Wednesdays at 7 p.m. and people can sign up by going to my website, which is improvelifepllc.com. And they put their email address in the little comment box. So I know people are very nervous, not only to talk during the meetings, but to even be known. So I wanted to make it anonymous, but during one of the classes that I took on how to run these groups is like for safety, you have to make sure that no like random creepers from the internet are there. So I need to know who you are. And I also need your emergency contact information, but you don't have to join the group, turn on your camera and say like, hi, first and last name. I mean, it's encouraged, but people need a little bit of chance to warm up to things. And I think once we get the ball rolling and everybody feels comfortable, everybody will be talking, everybody will know everybody. But I at least want to get some emergency contact information and I need to know who's in there. And, I want to make sure that just like is some stranger from the internet isn't just jumping on and eavesdropping, right?
Yeah.
So I have to ensure that doesn't
to vet
happen.
them a little bit. Yeah.
Yes, right. Oh, and I just wanted to give some examples of what we talked about during our first group discussion. So I'm very focused on specific goals and how to accomplish them. A lot of the groups are more like to vent and to just like share and talk, but it's just how I am. During my appointments, I start every session with what are 3 goals or 3 wishes, and then I type out how we achieve them, and then I send that plan. So if you don't, some people just want to vent, and if if you don't want to follow up or have any like plan, then you might not want to join this. But I'm like so focused on achieving things. So we had like 3 problems that people discussed, and then I came up with some solutions, and then I typed them up and emailed them to everybody. So the first one, people were talking about how they felt lonely when they had given birth. And so there's so many specific support groups like military moms or moms to babies in the NICU and things. So we typed those up, and getting over the hurdle of reaching out, because is anxiety provoking to message somebody and things like that. So people shared different ways to just like Nike, just do it. Like just text this person. And people shared stories of how they contacted people and then went out for coffee. And then afterwards they're like, wow, like I feel so much better. And then, of course, we talked about the anxious thoughts and unwanted thoughts, because like I said, that's one of the most life-changing, helpful things. And people are very relieved to hear that it is quite common. So we talked about ways to distract. And I don't want to push meds. I mean, I'm one of the few people on earth that wants to and does prescribe meds to pregnant women, but I don't want to be seen as like, that's the only thing
Dr. Pill Pusher.
So, I actually have videos on my website that like, this is not a pill mill. Please do not come and just ask for meds. So I went in, of course, the SSRIs for unwanted thoughts is great, but I was like, I don't want to seem like I'm pushing this. So we talked about distractions, having genuine interests in other things, the coping skills that you could do, stuff that when you catch yourself having the rumination, the perseveration of thought that you could do. So we typed those solutions out, emailed them. And then the last issue that we talked about during the group therapy is being overwhelmed, having kids and not sleeping and having to work, and then also the laundry, and somehow one extra kid is like 12 extra people's laundry. So there's this, I'm not sure if you're familiar, there's a nurse service that's overnight that they go to your house so that you could just get one night of sleep. So we sent that out, and what one actual full night of sleep can do for somebody's mental health, I'm going to tell you, it is great. So we talked about those issues and different solutions for them. So that's what our first meeting was like. I think it was pretty good. People commented that they found it to be pretty helpful, and it's free. So that's the best price.
For sure. I just feel like one of my biggest goals with this podcast and whatever comes from it is I just really want to I feel like the village was destroyed, like in our culture, it was just, it was bombed and burnt and it is gone. There is no village anymore, right? And so I feel like if I could just start getting people who want to just put their little brick in and start recreating this village brick by brick, that is what we need to do. And whether it looks the same as it used to, we did all used to live in a literal village, but now we can have a virtual village and we can reach out to each other through all these different resources. And so I just really think it's important for moms to know that you're not alone and there are ways to do this. And we can work on, getting past the cultural hurdle. There's so many mental cultural hurdles. Like we have this toxic independence now where we feel like if I can't do this by myself, then I have no worth. Or women fought so that I could go to work and have kids. And so who am I if I can't balance that? And it doesn't have to look that way. It doesn't have to look, you don't have to be this all-powerful superhero mom. You can do it with other people. You can lean on other people and you can find personal growth through learning from other people and reaching out and just networking and being that human that helps and touches the lives of other people because you receive that from others. And I just think it's so important for people to really realize that it's not weakness to reach out. It is how we connect with other humans. And that is part of the human experience. And that's why we're here. And that's why we're having children, to make more humans, so let's just all be human and reach out and recreate that village. So support groups are a great way to start doing that.
Exactly. And I like this phrase, toxic independence, because there should be a word or phrase to describe this situation or this that's going on. And you just did that for me, because that's like a thing that I didn't have a phrase for before, but now I do. Toxic. Yes, the toxic independence is a big, I'm writing that one down.
Yeah, because women just feel like, I don't know what it is, but women just feel like because we have these rights now or whatever, which that's debatable.
Wait.
We could go down that rabbit hole.
that's another podcast.
But because we have fought for our ability to go to work and our ability to be able to own a house and to have a credit card and not have to lean on a man, now we have to prove that we're worthy. And that means we have to be completely independent. And that's not true. We can lean on each other. We can help each other, and we can continue this movement to make life worthy and sustainable for women. And boy, you know what? The world's going to look a whole lot better when we do that.
Oh, for sure. Well, we gotta get the momentum and keep going with that. And the phrase here, I'll give you, like, you gave me a phrase, I'll give you a phrase. I obviously work, and then I have a 1-year-old and a 3-year-old, and then a husband, and I run marathons, and then I teach medical students.
Yeah.
And, like, there's a million things. So when I get to that threshold, before I'm like needing to have this toxic independence, I'll stop everybody around me, and I'll just shh, everybody listen. I cannot be everything to everyone all the time.
Right.
It is just not possible. Someone needs to chill for the next hour.
Yes.
Because so you could say, I cannot be everything to everyone all the time.
Correct.
And I have
it's
to
not your
people
job.
around me.
It's not your job. Like when, sometimes I'm not going to call my husband out, but it's like
a hypothetical person's husband.
Right. Say I want to go do something with some girlfriends, So then we're going to negotiate so that you can go do something. And how is that going to look? Am I going to take the kids, or are you going to take the kids? And how are we going to together make it happen so that we can both do the thing we want to do? And that may look like a babysitter. That may look like a trade. Last night my husband took the kids so I could go out with the Girl Scout moms. And that just means that, like, when Saturday comes, he gets to go to the gym or do whatever he wants, and I'm going to take the kids. Or if but it's not on you to make all of those things happen. It's on everybody working together.
Oh, absolutely.
I don't know why do moms feel like, and why do people feel like moms need to be doing all those things? We're all grown-ups.
I'm wondering, getting back to genetics again.
Right.
It's the two X chromosomes.
It must be something magical.
Maybe the Y chromosome has this alleviates you of the.
It absolves you. Yes,
I don't want to say. I don't want to be accused. I don't mean to make generalizations.
Right, but it feels that way. It really feels that way.
Right.
All right. Well, Dr. Waggel, is there anything else that you wanted to talk about?
Oh, there's plenty of things, but we'll
schedule that.
Be continued. Let me see. At some point we could talk about not eating sushi, not eating juice. What's up with not eating sprouts and the soft cheese? Why can't I take my cat's litter box? Actually, don't you make somebody else change the litter box?
My husband did.
Yeah. It's toxoplasmosis,
right?
But also, you're pregnant. You should rest.
Exactly.
If anything, you can use an excuse. But those are all things we could talk about at some. This is exciting. There's
so many things. All right, we're gonna start making lists, but I'm gonna pause. I'm gonna turn off the recording so that so that the audience doesn't have to listen to us brainstorm today.
It's a good idea.
All right, I'm gonna hit stop. But thank you so much.
Thank you. Yeah, it was really great.
Do you have questions that you wish a labor nurse could answer? As your due date approaches, do you wish you could pick someone's brain about all the things that might happen during your labor? When you meet with your OB or midwife, do you forget your questions in the moment? Do you feel like you need someone to take more time to walk you through what might happen in the hospital and how to truly mentally prepare? You're in luck, because I'm offering this as a free service in 2023. To get details on how to schedule a free session with me, email me at birthjourneysrn@gmail.com. Thank you so much for tuning into my podcast. If you enjoyed what you heard, make sure you hit that subscribe button so you don't miss out on future episodes. Don't forget to share the podcast with a friend who can benefit from the valuable insights that we share here. And if you could take a moment to leave a 5-star rating and review, it would mean the world to me. If you're ready to work one-on-one with me to embark on a transformational journey towards a confident and empowered hospital birth experience, go to kellyhoff.com kellyhoff.com/empowered and enroll in my Empowered Hospital Birth Coaching Program. Together, we'll create a roadmap to a birth experience that you'll cherish forever. That's kellyhoff.com/empowered. Let's make your birth experience extraordinary.